So I'd like to move on now to Ignasi Garcia, who's one of our close colleagues in Catalonia, who's going to tell us about the Catalonia model of integrated care. There's a lot of interesting work going on in Catalonia, including the use of information about how we join up health, particularly health, but also social care. And so I'm really looking forward to Ignacio. Thank you very much.
Okay, thank you. Thank you very much to all the organizers of this event. Thank you for the invitation. And I will try to explain some of the key features that we have already in Catalonia in trying to provide this integrated care model, and mainly on trying to engage clinicians to work within a single patient and with the same information, so that they can work all together with these kind of features. And, but let me just first set up slightly the floor. So what is Ticsalut Foundation? Ticsalut Foundation is just a tool that the Department of Health of Catalonia created back in 2006, trying to detect all the innovations and emergent use of technologies within the health sector. And so we also started developing all the standards that should be used in healthcare to share this kind of information within all the actors. So we are mainly engaged in innovation in healthcare by the use of new technologies. And so, therefore, we're mainly involved also in a lot of European projects that have become quite key e-health projects in the European Commission, such as EPSOS or Renewing Health. And I will just focus slightly on two new projects that were involved, which are these new tools for both for procuring authorities, but also they are interesting tools for companies, which are the Decipher, which is a project that is going to launch a tender using this pre-commercial procurement process. So we're just saying, this is our problem, we have some problems, we want solutions, and we're not the best ones in building business cases, but we do want the industry to provide us the solution. So we're open to any kind of technology solution, we're just willing to solve our problems. So these are the ones, the projects that we are really going to be involved in the very next future. Finally, the Catalan healthcare model is a completely decentralized healthcare model. So we have several healthcare providers that provide several and different healthcare services, but within a single public network. So I have a public insurer, and with that card, I can access any kind of healthcare provider. But all those healthcare providers are managed by themselves. So they have complete autonomy on their decisions and also on their kind of information systems that they use. So although we know that most of the primary care is managed by one single provider, which is the public one, there are quite a lot of acute hospitals that are managed by private organizations. They are not-for-profit organizations, but they are privately managed, and they have different IT systems. So therefore, interoperability is a kind of a must for us as a region to really share this information about our patients. So the real picture more or less looks like this. So me as a user, I can access, I have an insurance, a public insurance, which covers the 100% of population in Catalonia, and all the population can access the healthcare providers that can be a public healthcare provider, which is the Catalan Institute of Health, or can be contracted providers. And as I previously mentioned, 80% of acute hospitals are privately managed, and 20% of primary care is privately managed. So because of that, everybody chose their own hospital information system, their own information system to manage their clinical information. So there was a decision that ICT should be one of the key issues to integrate all this information to go and solve the health conditions of patients. So we know which is more or less the environment. We know that we have budget reductions. We know that we are increasing the chronicity levels elsewhere. We also need to guarantee the quality of the service that we are providing. We are public administration, so we have to guarantee these kind of issues. So finally, what we've got here is a real big challenge. So we have to still provide efficiently all the services that we're providing right now, and we have to increase the number of services that we are just right now providing, because we will have much more patients that require those services. So we have to really change all the environment, the processes, and also the technologies that we are using at this point in time. So what we have in Catalonia is the shared clinical record, or the shared medical record. And what is this? It is only a system that has all the medical records of a specific patient. And clinicians can access this information independently of where that information was generated. So all the information about the patient can be accessed centrally, but it is not stored centrally. All the information is kept on their original places. So all the healthcare providers have their own information, and we're just allowing this kind of access to all the other interested parties when they have a patient that they have to treat. So we have different sources of information of all the data that is stored in this shared medical record. We have for sure the first information that we need is that user is in fact a user of the public insurance service. And from there we collect the citizens' information. And then after that we can collect all the information about healthcare events. So all of the acute hospitals and the primary care events that took place can be accessed from this record. And also we have other sources which are kept by maybe by the Department of Health or other departments within the government of Catalonia that are also accessible in this record. So what we're talking about specifically is that we have diagnoses, we have healthcare reports, we have immunizations that are generated from primary care centers. And we have discharge reports, emergency reports, and also specialized outpatient clinical reports that were generated by acute hospitals or specialized centers. And then we have also some diagnostic procedures, even also interventions and any kind of radiological image can be also accessed in this record. And what I was telling before is that other sources of information, for example, all the prescription of drugs is kept in another record, in another system, that it was integrated with this shared medical record, so that all the clinicians are aware of all the drugs that are being prescribed to a specific patient. And also, for example, the Advanced Directives Registry is how the palliative care has to be managed according to the patient's decision. And this is also included in this medical record. So I have just these two images about the medical record. It is mainly for professionals, for clinical professionals, and it has to be used under clinical constraints. So I will just show this. But the innovation that I wanted to explain today is about how we have included in the shared medical record the categorization or the stratification of patients for all the clinicians. So, I just forgot that I had some information about the deployment. So the numbers that we have, almost 90% of hospitals and primary care, but also social care, but it's socio-sanitary care. And mental care, they also have access to this shared medical record. And this is the numbers on accesses, on documents that are available. So we have more than 52 million documents in the shared medical record. And every single year we are producing more than 16 million documents per year. So we have, in fact, 5.7 million patients with reports, and we have a population of 7 million. And you would ask me, okay, so there's a 1.3 million out of here? No, this is just because the shared medical record was started, and all the sharing of clinical information was started back in 2006. So if a patient did not have any kind of admission to a hospital or did not have any kind of treatment, they do not have any kind of record in the shared medical record. So this is what I was telling you just before, that we're allowing now the profiling, this certification of patients, so that all the clinicians that treat a specific patient, they know the frailty of that patient. So we have two labels. So PCC, it's the acronym in Catalan for chronic condition patient. And MACA is for advanced chronic condition. So what we have here is that we label them, and they have some colors, and this is always available as one of the, we can see it here, like you have the name of the patient, and right on the right-hand side of the patient, you have the label, if this is a complex chronic patient, and with the color. And this was only started this year, so in January it was started. And so that the GPs had to start with this labeling of patients. But in July this year, it was also started an automatic way of stratification of all those patients using the clinical risk groups algorithms, so that we have quite a lot of patients right now also with this stratification. So, and this, what it allows, so it allows that the clinicians can define a shared individual intervention plan. So they can specifically, they can define which is the process that that specific patient should follow, for example, in case of an exacerbation. So how they should be treated, or if they have any wills on how to be treated. And also several information about medication, about allergies, about all the diagnoses, about the care, and or if they have a care that they delegated the decision that it has to be made. So this process it has been quite fast, and right now we have more than 53,000 patients already with this labeling. So, and in fact, we just overcome our objective because we defined that by 2015 we should have 25,000 patients or complex chronic patients already identified, and at this point in time, about 2 weeks ago, we already had more than 53,000. So it has been quite a good strategy. This is a screenshot of the clinical workstation for GPs. So they always know which is their number of complex chronic patients that they have under their population, under their care population, so that they can follow proactively this kind of patients. And this was about the shared medical record. And on top of that, we also built what we call the personal health channel, which is just having all this information, all this clinical information also available for the patient, so that they can manage their own clinical health conditions, and they can have the information and know exactly how to deal with that kind of conditions. So right now we're allowing this access to information, to clinical information, but we're building all the environment to make this personal health record a kind of more interactive, so they can really manage their own condition, so that it's a kind of more preventive tool, and it allows the self-control. And for sure, this is not something that we're going to do alone as a public authority. But as we have here, this is all the reports that can be accessed by the clinicians. They are also available for the patient, and you can search for some reports and according to some filters. Then you also have the diagnosis that you have active or non-active, so that this is also structured information, so that it can be also searched. And then you can also access the prescription of drugs that you have active. And for example, if you have a telephone consultation with your doctor, then he updates your medication, and then you can access from here and print the new prescription sheet and go to the pharmacist and just take your drugs. This is about vaccinations. And the final point that I wanted to make is that we're not just building this personal health channel, this personal health record alone. We want to build a kind of ecosystem so that third-party providers can define services that can be access through the personal health channel, so that they could collect information from the personal health channel and send back this kind of information to the personal health channel, so that both the patient and the clinicians have this specific follow-up information on this kind of structure to allow the self-management and on the follow-up of chronic patients. And that was all I wanted to say.
Thank you, Ignasi. That was fantastic. I mean, the reason I was really pleased that Ignasi came today is because there's quite a lot of similarities to what they're doing in Catalonia as to what we need to do in Kent. Some of their solutions are a bit further ahead than ours, but some of them we could definitely learn from, and some of ours, there are ways that we could contribute to that to Catalonia. So I think that the technology solutions that Catalonia wants, they want industry to provide. Well, I think we should be getting into that space as well. Interoperability is one of the key issues, and I think that's not necessarily the same IT system, but it's how can we actually start to give the citizen, the individual, ownership of their own information, and how can we move that forward. So we're very keen to work with Catalonia to see if there's any similarities that we can really, so that we can upscale this, because this interoperability and the sharing of information is absolutely key as we move into new ways of working, particularly around advanced directives and palliative care. So thank you very much.